Hi class, and welcome to the module on experimental research design. I think it's always nice at this juncture to stop and do a quick refresher on the purpose of research and why we conduct research. One of the basic reasons we conduct research is to describe a phenomena, an event, a behavior, a personality characteristic, attitudes, something like that. And we also want to usually take that further and be able to predict human behavior. And to be able to say, knowing this set of factors, can we predict how somebody will behave or believe or engage with somebody? And this helps us to determine causes of some characteristics, attitudes, behaviors, or events. And causal effects are really defined as a variation in the dependent variable, and I'll run back through those definitions again in just a second, that follows some variation in the independent variable. So we can look at, for example, if we're looking at scores, we can look at all of the scores on the independent variable and see the ways in which those varying scores, all the different scores that people have on whatever scale, predict what kind of scores they will have on another scale or how they will play out at another variable, all other things being equal. And ultimately, for most sexuality researchers, for a lot of public health researchers particularly, the end goal is to try to intervene upon or improve some behavior or behavioral outcomes or change attitudes. So often our sort of late game or end stage game is about behavior change or attitude change. And as you'll see in the book, a lot of the information is geared towards that ultimate goal. For some of us, that may not be the goal. We may be curious about something. We may want to understand something that we see happening in the world, some phenomena. But for most of what we do, the intervention piece is sort of that end goal. And so when we think about causality, in terms of what not only predicts something or is associated with another variable, but causes another variable, as your book notes in one of the tables in chapter 5, there are 3 necessary conditions for causation. The first is that there is a relationship or a correlation. As we talked about before, correlation does not equal causation, so that alone is not sufficient to conclude that there is causation. As we talked about before, there can be correlation, and it can be difficult to determine if one variable causes the other, or if there's some third variable out there that explains that association between those 2 variables. And so it's a necessary component of causation, but not sufficient on its own. And when we talk about correlation, it may be helpful to sort of break that out a little bit, and we'll talk much more about that at the end of the semester. But when we talk about correlation, we're talking about 2 variables moving together. So as I said before, the independent variable has all of this variation, the dependent variable has all of this variation. And when we're examining a correlation, we're looking to see if the variation in one variable can help us understand the variation in the other variable. So in a negative correlation, we're saying that as one variable goes up, so for example, as this predictor variable goes up in score, the dependent variable or the outcome variable goes down in score. So this can be something like, for example, as sexual anxiety increases, sexual satisfaction decreases. So the higher scores on sexual anxiety, the lower scores on sexual satisfaction. A positive correlation, on the other hand, is when both variables are moving in the same direction. When one goes up, the other goes up. When one goes down, the other goes down. And this could be something like relationship satisfaction and sexual satisfaction. So the more of one you have, the higher the scores on one, the higher the scores on the other. And again, we don't know that that's causation, especially for 2 variables like that, constructs like that, relationship satisfaction and sexual satisfaction. They're likely working in tandem with one another. So we may see this correlation here, this association, but we don't have the information to be able to conclude causation. The second condition that is important for making a claim of causality or causation is temporal priority of the independent variable. And what that means is that the variable that you're thinking about as being the variable that causes a change in another variable comes before the other one. And so in so many cases, this is really hard to determine. So for example, relationship and satisfaction, sexual satisfaction, it's a little bit of a chicken and an egg situation there. And so we'll talk a little bit more as we get into some of the other methods about how we set up a study to be able to examine causation. And then finally, there is a lack of an alternative explanation. And again, this can be a challenging one to determine as well, because we don't design studies where we measure everything. So there often can be some alternative explanation, but based on what we measured, based on what we know, we don't have an alternative explanation. So those are those three conditions that we talk about as being necessary for causation. And the reason I review the sort of purpose of research as well as the conditions of causation is because experimental research is really designed to be able to help us make claims about causation. In observational research, we really can't do that largely. There are some longitudinal studies that can get a little closer to some claims of causation, but experimental research is really the sort of one true way that we can really understand causation. And so in experimental designs, part of the reason that we can conclude causation is that we are the ones actively manipulating factors. And this facilitates a lot of control for us over our variables of interest. And so we can sort of isolate the cause and effect and be able to remove the effects of other variables, so extraneous variables or noise. There are various kinds of experiments that you'll see in the literature. Some are done in labs or in research settings, whereas others are done out in real world, what we call the field. And again, this is the best design to be able to test causal hypotheses or answer questions about causality. And there are a ton of experimental designs to choose from, and they all have their own strengths and weaknesses and sort of times and places. And ultimately, our research questions, as you'll hear me say a million times, the research question is kind of the core of our decision-making processes. And we also have to think, obviously, about ethical considerations, practical considerations, financial considerations, things like time, access to resources, access to participants, how long we can keep them, all sorts of things like that will play into your decisions about which experimental design is appropriate for your question. So a quick overview of some definitions, and then we'll jump into some of those experimental designs. So first, an experimental group is the group that gets your manipulation or your intervention. Your book presents some of the nomenclature that's really traditionally used around experimental design. I've presented that in the past, and I've actually taken it out of this lecture because the book has it, and I think it's more important to think conceptually rather than learning that language. But this experimental group is the group that gets whatever manipulation that you are interested in examining the effects of. And there may be multiple experimental groups in different studies depending on what you're doing. But there's also a control group. And a control group doesn't get your intervention or your manipulation or whatever it is that you're looking to see the effects of. A really important question, though, is what do they get? Particularly for health interventions, behavioral health interventions, it's really important to think about the role of attention. So having somebody pay attention to you, having somebody monitor you, engaging or interacting with somebody, so sort of those social or relational effects. And so if you have a control condition where people are getting nothing, they're not coming in for anything, they're not doing any sort of interaction or engagement with you, whereas your experimental group is getting all of this engagement. So maybe they have 4 sessions of motivational interviewing or something like that. Having a control condition in which there is nothing makes it a little bit more challenging to know if the effects of your manipulation or your intervention are due to the effects of the intervention or just due to paying attention to people. I often talk about when, well, I'm not going to say that example, that's a long story. So the control condition, it's really important to think about what they do get, and if you're able to examine the effects of the actual experimental manipulation that you're doing, or if you're getting some sort of attention effects. It's also really important to think about control condition in terms of what people out in the world are getting. We think about this a lot in HIV intervention conditions. For most people who are going to their doctor on a somewhat regular basis, or going to a place where they can get an HIV test. For most places where you get an HIV test, you'll get pre-test and post-test counseling. You'll have a conversation about your risk behavior. And so when we design new interventions that we think and hope will be better at encouraging HIV prevention behavior, encouraging testing, etc., we want to be able to compare that intervention to what's already out there. So we can compare it to nothing and say it's better than nothing, but what we don't know is whether or not it's better than what already exists in the world. So some people will call that standard of care. So particularly for HIV interventions, teen pregnancy interventions, things in which we already have some level of engagement and involvement in prevention work out in the world, it can be even more important to think about what it is that we're comparing our intervention or manipulation group to. Random assignment is a really key piece of experimental design. It is, in a lot of ways, sort of the key piece of experimental design. Random assignment refers to randomly assigning your participants to your different groups. So experimental versus control group, treatment or intervention group versus control group. And the reason that we do that is so that we can say that before they got the intervention, before they were exposed to our manipulation or our intervention or our control condition, that those groups were the same as one another. And by randomly assigning people to each of those groups, we assume that all of that natural variation between people, so gender, socioeconomic status, education, all of that kind of stuff will shake out pretty evenly if we randomly assign people to groups. We'll talk next week about sampling and random sampling, and I find that students get those confused a lot. So we'll distinguish next week a little bit more between random sampling versus random assignment. And so in this instance, we're talking about random assignment to the experimental conditions or the control group. In some cases, we do sort of a little bit better than random assignment, in which we try and match those groups at the outset. So we may say, all right, I have this pool of people, and I want to make sure that the groups are even, my experimental group versus my control group. And so I'm going to match everybody up in this pool. So this is a 28-year-old woman who has a medium level of education, whatever that would be, and is African American and high socioeconomic status. Here is another woman that is very similar, if not the same on all of those factors. We're going to put those two together and randomly assign each of them to one of those two conditions. So it tries to have a little bit more control over that random assignment process than the sort of basic random assignment does. So we'll talk a little bit about pre-test and post-tests. All experiments have a post-test. That's a measurement of that outcome variable or that dependent variable after the exposure to either the experimental or the control condition, or multiple experimental or control conditions. And the pretest, on the other hand, is the measurement period that comes before an exposure to whatever our manipulation or intervention is. Many true experiments have a pretest measurement point, And so that's the measurement of that dependent variable again before we do anything to people, before we expose them to anything, do any sort of manipulation. It's not required because we assume that if we're randomly assigning people to conditions, that those people are going to be the same on both of those things. But in many cases, we do want some sort of pre-manipulation, pre-intervention measurement of what's happening in people's lives. Some of that is about statistical reasons and being able to see where somebody has changed. So for an individual person, how far have they come and how is that different? It also allows us to check on our randomization to see that it's actually worked on our random assignment. And so that's a good thing to do. Some of the concern in some cases with pretesting is that if you're measuring the same thing multiple times, people will get a sense of what you're looking for and also have some practice effects on that measurement or some memory. And so they might say, I did the same depression measure 6 weeks ago. I'm just going to try and remember what I put and put the same thing when we're actually trying to see change. So quick overview of independent versus dependent variables. In experimental research, you'll often hear independent versus dependent variables. In more observational research, you'll typically hear predictor versus outcome, though a lot of people use those interchangeably across both types of designs. So you can think of those a little bit interchangeably. Independent variable is the variable that we are manipulating in experimental research. So for example, if we're talking about testing an intervention that is an HIV prevention intervention, and we have this amazing 4-session motivational interviewing intervention that we're going to give people, and then we have 4 sessions for the control condition where they watch a video that tells them to have safe sex. Which is often what you get at doctors or sort of pre-test, post-test counseling is reminders to be safe. And so what our independent variable is the condition, and there are 2 levels of that, experimental versus control. A lot of people get confused and think that there are 2 independent variables, the experimental condition and the control condition, but that's actually 1 variable, and there are multiple levels of that categorical variable. And then our dependent variable is the outcome variable of interest. So whatever we think that our manipulation or our condition may have an effect on. So for example, if we're talking about safer sex behaviors associated with an HIV intervention, that intervention would have that independent variable of control versus intervention. And then we may look at, for example, number of risk acts or whether or not people got tested for HIV after their intervention, things like that. So we think it's what's going to be impacted by our manipulation, by our independent variable. And again, in observational research, that's sometimes called an outcome variable. So let's talk about a few different designs. We'll talk about pre-experimental, true experimental, and quasi-experimental designs in this lecture, and we'll talk about some of the subtypes underneath of them. Your book goes into a ton of detail about these, so I won't belabor some of these points over and over, but I do think talking about them a little bit more is useful. So in pre-experimental designs, we have situations in which, so for example, one-shot case study design. We have a single group, we're exposing them to a treatment. So for example, I'm going to try out this new therapy modality, and I'm going to do that therapy and then measure people on some variable or set of variables after that treatment. So there's no randomization or no random assignment to condition or group, there's no control group, and there's no pre-testing. So some of the basic components of experiments of true experiments are not present here. A one group pre-test, post-test design is somewhat similar, but you have just the single group who has a pre-test and then a treatment and then a post-test measure. And so again, no random assignment here. The advantages to this design, to these designs, these experimental designs, are that they're good in situations where ethical issues may prevent differential treatment. So for example, let's say you are a therapist and you want to say, I learned this new thing, DBT, and I'm going to try it out on some of my patients, and I'm going to see how they do. I'm either going to measure them before and after, or just after. But you don't necessarily want to say, I have this other group of clients who I think would be great candidates for this, but I'm going to withhold that and see how they do as well. That would be unethical in lots of situations. And so this can be really good for those sorts of scenarios in which we can't have a control group for whatever reason. And this can be really good for us in pilot test situations where we're just trying to like look at something and test it out and see if there's a signal. I often say, like, do we see that scores got better, or that, for example, depression scores are low in this group? And if so, that may say to us, all right, this is worthy of a little bit more rigorous investigation. I'm going to design a study that has a more rigorous design that will allow me to look at cause and effect a little bit more closely. Disadvantages, obviously, are that we can't control for all sorts of other stuff that may be happening in the situation, and we don't have random assignment, so we can't make any sort of causal conclusions here. True experimental designs, as I've mentioned, the true experimental designs typically involve a control group to establish a relationship and control for some confounding variables. And true experiments have to have random assignment to the two or more conditions. And that helps to reduce the impact of all of these other confounding variables, like the gender and education and socioeconomic status, that may play a role in how people respond to those manipulations or interventions. But if we can distribute those confounding variables evenly across the groups, then we can kind of remove the effects of that, the potential effects of that. There, again, are a variety of true experimental designs. A post-test control group design is where we first introduce randomization. And this, again, helps to make the groups hopefully fairly equal before we do any sort of exposure to a manipulation. And so in this situation, we randomize people to control and experimental groups. We expose them to whatever our manipulation is or the control condition, and then we do an observation or a measurement. And so we don't have a pretest here, but this allows us to sort of remove or control for the potential effects of a pretest, as I mentioned before. This just takes that same design and gives us a pretest. So random assignment, pretest, exposure, and post-test. And we'll talk a bit more about internal validity in just a second, but this design controls for some of the threats to internal validity and allows for us to do those pretest comparisons to be able to make sure that our random assignment worked and the groups are actually equivalent to one another. Again, there's the potential effects of pretesting. So reporting on the pretest affects our behavior, or we have some testing effects where you learn the responses that you need to that test so that you respond differently on the post-test. This design is often known as a randomized controlled trial. This is the gold standard of clinical trials. So when we're talking about RCTs, as they're sometimes called, randomized controlled trials or clinical randomized controlled trials, we see over here that we have this assessment for eligibility for the study, and then we randomize people to the intervention or control conditions, and so they received whatever, they did not receive whatever, they're in a control condition, and then we have this follow-up point where we do that same measurement that we do at the beginning, and then we conduct analyses. And so this is sort of a flowchart of how that basically looks. When we're talking about randomized controlled trials, it's a situation in which whether we're doing a lab or a field-based experiment is actually really important here. When we're talking about a lab study or a study that's in an environment that we wouldn't actually place that intervention, we're talking about the effects as efficacy. So do we see some effect of our intervention? Do we demonstrate efficacy? And then when we take that out into the real world and put that in a situation like in a clinic or a school or a hospital or something like that, and then we demonstrate effects, we're talking about effectiveness. So this is actually out in the real world. Does this intervention have the effects that we think it will be? This method is pretty labor and time and financially intensive. So typically people apply for huge federal funding dollars to do this kind of research and do it well. And so for most of you going on to dissertation work, this will not be the kind of work that you do. But for many of you who go on to work in clinical settings perhaps, or to design and test curriculum, this might be some of the kind of work that you'll see. And so, as I mentioned before, sometimes we match our groups. So there are some experimental designs that capitalize on this matching technique. And so in a matched pairs group design, there are pairs of participants or sometimes sites, so like clinics or hospitals or schools, that are matched on a variety of variables that we think may have an effect. So again, it could be socioeconomic status, location, all sorts of things that we think may have an impact, and we can match our people or our sites on those variables. So we match people, we randomly assign each of those people in those pairs to one of our conditions. We do a measurement or an observation. We then expose people to whatever it is that we're testing, an intervention and control condition. And then we do another measurement or observation. Somewhat similar, a within subjects or repeated measures design is a situation in which people serve as in both the experimental group and in the control group. And so we say participants are kind of their own controls in this situation. And so each participant receives both conditions. So we may have an intervention, we may have a control, we may be comparing different interventions, in which case this would be a relevant design. And so each participant gets both conditions, and participants are randomly assigned to the ordering of these conditions. So for example, one group of people may have a random assignment to groups, then a measurement or observation, then they receive condition 1, then they have another measurement or observation, then they receive condition 2, then they receive another observation or measurement. And in the other condition, we flip those around. So this is sometimes called counterbalancing. And so we'll counterbalance the order in which they receive each of these interventions. And so then we would randomly assign people to the groups in which they're going to be ordered, if that makes sense. We don't use this all that terribly often, particularly in health research, because there are carryover effects. So if we think about condition 1 in this example and condition 2 being two different kinds of curriculum, we know that people, well, we hope that people will retain whatever we tell them in this curriculum number 1, and then we can observe them, and then they'll learn additional information in this curriculum number 2, and then we'll observe again. So we don't know that this observation can be tied to this condition, this curriculum, or the original one, because the effects of that are likely to carry on for people. So this is sometimes used for more subtle or brief kinds of exposures. So for example, if we wanted to look at media effects and we wanted to show people a bunch of media with sort of, I hate the word normal, but normal sized people, not airbrushed, supermodels and things like that. And then we wanted to measure, let's say, body satisfaction after we show them normal looking people with sort of the average variation that we see in the real world, and then measure body satisfaction, and then look at exposure to airbrushed, super thin, white supermodels, and then we measure their body satisfaction. So a crossover design in this way might be more appropriate in that situation. So that really depends on what we're manipulating, what we're exposing people to, what we're measuring. And then finally, quasi-experimental designs are basically experimental designs that do not involve random assignment to condition. So they may or may not involve a control group, And again, there are a whole host of quasi-experimental design options. I'll go over a few, your book goes over a few, but know that for each of these, there are so many more designs than your book or I cover. Under quasi-experimental designs, there is a non-equivalent control group design. This is somewhat similar to the match pairs between group design that we just talked about on the last slide, but we don't have that random assignment to condition, which might be impossible or might be unethical for some reason. So for example, schools may already be getting a particular curriculum, or therapists may be doing a particular modality, and we can't randomly assign people. They are in the school that they're in, they're with the therapist that they're with, and so we may not always be able to do that random assignment. And so there are non-equivalent groups with post-test only and with pre-test, post-test, similar to what we looked at before. And then there's also interrupted time series design. And your book does I think your book does nice pictures of all of these with the little smiley faces, I think, that are kind of helpful. And in the interrupted time series design, you have multiple observations or measurement points, then an exposure to whatever your manipulation is, followed by, again, another series of multiple observations. And this design can be useful if you're interested in maturation effects, and it allows you to examine sort of natural change in that variable that we may see even without any sort of intervention or exposure to a condition. So that can help us really understand and be able to differentiate between maturation effects and experimental effects. But again, as we talked about with multiple testing points, we can have some impact of having to answer the same questions or measure the same thing over and over on people's responses to that measurement. So key pieces to all of this are thinking about internal and external validity. So we'll talk first about internal validity. And internal validity refers to the truth in our conclusions about causality. So if we say after an experiment that we think this variable, this manipulation, this intervention caused this other outcome or change in a dependent variable, the internal validity refers to the truth in that conclusion. And there are all sorts of threats to thinking about internal validity or to having a study that is internally valid. So your book highlights these in chapter 5 or in table 5.2, which I think is a nice little synopsis, and then it goes over each of them more fully. But there are history effects, which are external events during the experiment. So maybe you have major events in the news that people find out about and that change their attitudes or behaviors. In HIV, a big one that I think about is the introduction of PrEP, pre-exposure prophylaxis, which is probably most of you know a pill that you can take every day to prevent HIV transmission, even if you are engaged in unprotected sex with an HIV positive person. And so there are all these HIV prevention interventions that are always happening. And for some of those, right in the middle of them, PrEP happened. And so that's a huge natural event in the world, but external event in the world that we have to think about when we talk about the effects of our intervention on, for example, the number of people who became HIV positive. That's a huge external piece. So we may not be able to say that our intervention drastically reduced HIV infection, but it was that during our intervention, during the course of that intervention, PrEP was introduced, and that massively reduced transmission. There are also maturation effects, which is really relevant when we're conducting a study that is longitudinal and takes place over a long period of time. So participants mature and then the outcomes change. So like knowledge about sexual risk behavior or relationships or things like that. There are also testing effects, which we talked about before. The pre-testing impacts post-testing. People get good at tests. They know what you're looking for. They try and remember what they said the last time. If your instruments change at all between tests, this can be a really difficult thing in terms of being able to conclude truthfully that there was a causation between one variable and another. If you're measuring two different outcomes, for example, at each time period, or measuring the same outcome, measuring it in two different ways, then that can be problematic. If you have differential selections, this is where random assignment comes in. If you have some sort of pre-existing differences between your groups before exposure to whatever manipulation you're doing, that can limit your ability to conclude that there was cause and effect. So this is one of the upsides to pre-testing, is to be able to check and make sure that that the random assignment has been successful. Statistical regression, or what's sometimes known as regression to the mean. This is a tendency for scores to move towards the mean. So very high scores can only go down, and very low scores can only go up. And so when we have these extreme ends, they can only move in that one direction. So there's this tendency for that, and so that can impact the conclusions that we make about the change in those scores. We have mortality or attrition, which is death or discontinuation of participation. So mortality typically refers more to death, whereas attrition is people just stopping your intervention. And so if you have a whole bunch of people who stop your intervention because they hate it, because they hate you, because it's not convenient, all sorts of reasons people might stop it, then with the people we do have left, we make a conclusion about the effects of that intervention or that manipulation. But those effects are in doubt a little bit if we have a whole bunch of people who quit. So maybe we have some cause and effect, but only among the people who really stuck through it and got over some hurdles or some obstacles. And that may be a very different group of people than the full sample. So the Hawthorne effect is a situation in which we see changes in behavior because people know that they're being watched. So if I have to perform a behavior in front of somebody, or if I know that somebody's going to be measuring my food intake, for example, I may say like, oh, I'm not going to have that second or third beer or whatever, because I know I have to write that down and somebody's going to look at that. So that the very nature of being observed may change your behavior. And then probably you're all familiar with the placebo effect. This is a situation in which we have changes in behavior because we expect there to be an effect of the treatment. So I went through, whatever intervention, and I had a pill, I got this treatment, and I expect that I'm going to feel better. And in fact, that expectation is powerful, and we may actually feel better. So it's not like in the placebo effect we're lying. It may be that we actually do experience those effects because we believe so strongly that we will experience those effects. And then finally, diffusion of treatment refers to a situation in which a treatment effect spills over into the other group. So typically we're talking about experimental diffusion to the control group. This I've seen some in HIV prevention work or HIV intervention work. We did a study once of medication adherence among people in New York City who were HIV positive. And people would often come in with their friends or with their partners. And so if you're randomly assigning people to groups, one of those people may go into an intervention condition and one may go into a control condition, but then they go home together. And so all of that great stuff, hopefully great stuff that you did in the intervention, that one partner may say to the other person, I learned all this great stuff, you should do this with me. And so that limits your ability to be able to say that the intervention condition was better than the control condition. You may find that it's more similar because some of those effects were diffused across conditions. So those are the internal validity pieces. So again, the internal validity refers to the truth or validity of your claims of causality or of association. External validity is what most of us think about as generalizability. So can we take these results and generalize them to other populations, to the real world? And so there are a variety of threats to external validity. One of the ones that I think we think about most commonly is sample generalizability. So are these people the same as the population from which they are drawn? And we'll talk more next week about the distinctions between sample and population. But are the 200 women that I surveyed different than women overall, or women in this area, or whatever I'm thinking about as my population? And can we generalize our results beyond that population? So if I looked only at college women, can I say that this is true for women in general? Can I say that these results are true for men, for college men? So can we generalize beyond the population that we drew the sample from? There's also interactions of testing and treatment. So the intervention may only have specific effects when it's combined with that pre-testing and monitoring of behavior. So that's a testing and treatment interaction. There may also be an interaction between the setting in which the intervention or manipulation is occurring and the treatment itself. So maybe that intervention only works in a research situation, but you can't actually put it in the hospital because it doesn't have the same effects. So that's a setting and treatment interaction. There are a host of other threats to external validity that your book thinks about a little bit and gives you a little bit of an overview on. I think that there is a table that summarizes those as well, and I would encourage you to look at some of those descriptions of internal and external validity. I'll provide this checklist here. This is from one of Creswell's textbooks. He's a very popular research methods textbook writer. So I'll leave this here and not talk a lot about it, but it is something that I'll refer back to as we think about evaluating the evidence that we have. So thinking about who are the participants, who is our sample, who makes up our sample, and what is the population that they're drawn from. How are they going to be selected? We'll talk more about that next week. Will they be randomly assigned? If not, will they be matched? How many are in each group? We'll talk more about the importance of the number as we get towards the end of the semester. What's the dependent variable? How will it be measured? Will it be measured before and after? We'll talk more about measurements as we move forward, and you'll learn about reliability and validity. What's the treatment condition, or what's the manipulation or exposure? How are we operationalizing and defining that? Will we measure other variables that are covariates or extraneous variables? And which design will we use? What are the different steps? And then, as we just reviewed, what are the threats to internal and external validity, and how will you address them and try and minimize them, hopefully. And your book talks about some strategies around trying to minimize those influences and those threats to internal and external validity. And then finally, how are we going to interpret these results? How are we going to think about what they mean, their implications for practice, etc.? So I'll conclude with a couple of pointers and a quick summary. As I mentioned at the beginning, as I'll mention a million more times, I'm sure, choosing a research design involves so many factors. And I think the first and the most important really is that research question. So what is it that you really want to know? Do you want to examine a causal effect? And is that even possible in your situation? Obviously, ethical issues are huge here. So how can you address your question without violating any laws or harming anybody? Can it pass through an IRB? Or do you need to be a reality television show producer instead? What kind of study can you afford? What's your funding, if any? How likely will you be, is it that you'll be able to carry out the design in your lifetime? Logistically, financially, all of that stuff. Who is available to you for your study, or what sites are available to you for your study? So all of these are really key factors when you're making these decisions about design. And I think it's important to remember that all these designs, including the best designed experimental, or the sort of best laid out experimental designs, have strengths and weaknesses. So it's important to realize these and think about these when we choose the design, when we make conclusions based on our results, and when we discuss those limitations, which any good research paper should do. Again, it's important to have a well-defined research question that really guides these decisions and helps us think through them, and really acknowledge what those strengths and weaknesses are. So nothing is ever going to be perfect. We're always sort of having trade-offs about threats to internal validity versus strengths that we get regarding external validity, or strengths of a measurement point or a measurement type, versus not doing that to try and guard against testing effects. And so there's always sort of a push and pull that we have here, and it's important to know what those are and to know how they impact the evidence that research produces, so that we can do a better job of evaluating the quality of that evidence and how that evidence applies in different situations. And those are the sort of researcher thinking skills that I want you to leave this class with. Again, research question is most important. So if you have questions or thoughts, this is a lot of material in this design piece. So if you have questions or thoughts about observational or experimental designs, post those under the general discussion forum, and I'll do my best to answer those in a written format. When we get to the individual meetings, if you have questions about these things that you want to pick my brain about, I'm happy to chat about those in that space and time as well. And that's it for this lecture. Thanks all.